Well, I'm Allison Smego. I'm at University of Utah and Intermountain Health in Salt Lake City, and happy to present to you guys on how we've improved our retinal screening. Okay, just a weird picture here. Okay, so just to give you a little background on our hospital and our clinic. So we're located in Salt Lake. Is this a pointer? Okay, cool. Which is kind of like right there, that like slightly blue one. Um, and we have a number of different outreach locations. All of these little bubbles with the IH are Intermountain facilities, but they're not all ones that we currently go to. So we cover a lot of the state. We have a second primary location, which is about 40 minutes south of us in Lehigh. And then we also have three other outreach locations as well. We have, as you can see, a large catchment area from multiple states. And uniquely, we have about 75% of our patients are on private insurance and only about a quarter are on public insurance, which I know is different from a lot of centers here. We have about 2,500 and growing patients with type 1 diabetes, with about 400 new diagnoses a year, and then 300 and growing patients with type 2 diabetes. So, preaching to the choir, but diabetic retinopathy is one of the leading causes of blindness in adults. And regular screening allows for timely detection and intervention to ultimately reduce the risk of vision loss in these patients long term. Um, our clinic historically really struggled to get these retinal exams done and to get the records sent to us. And so we had a big unknown for these patients, and we really wanted to prioritize improving this for our population. So that leads me to our goals. So our aim was to increase retinal exams among patients with diabetes in alignment with the ADA screening recommendations. And we started this in early 2024. And so our goal was to improve this by December of 2024 initially. So for our patients with type 1 diabetes, we aim to go from 75 to 82%. A weird number, but yes, we aimed for 82%. And then with type 2 diabetes, from 50 to 55%. And notably, this pilot was in our main Salt Lake location for starters. So a couple of the key drivers that we identified as barriers to why the eye exams weren't getting done. We If patients were having them done, we were not consistently getting the documentation sent to us. Since patients are coming from such a large area, they were going all over the place as far as where they were getting these eye exams done. And then if they were getting sent to us, they were sometimes getting scanned into the medical records, sometimes showing up in like our folders, sometimes just disappearing as things often do. And then we also had providers that were maybe not as up to date or weren't as bought in on the ADA recommendations as far as screening. And so we really focused on educating and providing resources for those providers. And then also just the burden of having another office visit is quite significant for a lot of families. And so going to another location, taking off work or school and paying for the travel there was burdensome. So our initial interventions were really focused on documenting the retinal exam, so documenting this being done. We changed the way our intake forms occurred, and so our MAs were asking at every visit if the patients had had a recent eye exam, and then documenting that. So we had this. This is a Cerner. This is from our Cerner EMR. For those that are familiar, so we started utilizing this diabetes eye exam form that we could enter in when it was done. And if you notice, it allows you to note whether it was scanned into the EMR or not, and then you can change the date. And then we helped all the MAs and providers set up filters so you could easily go in and see when their last eye exam was done instead of having to scroll through the endless number of documentations that are in the EMR. And then we ultimately got a RetinaView camera. So we were fortunate enough to have support of the institution to buy a camera and start doing the retinal screening in our clinic. Again, this was at our main hospital location, and the RetinaView camera is there's a picture there, but basically you can take it from clinic to clinic or room to room and take pictures of the kids' eyes after they've been in the dark for about 5 minutes. It's billed through their insurance, typically just through their regular health insurance, because most health insurances allow one eye exam per year. And so it was really well received by patients. This is just a workflow of what this all looked like for our patients and for the staff in clinic. So if they were eligible for the eye exam and were open to doing it, then our MAs would go ahead and do that. The pictures then sent off to ophthalmologists that we contract with, who are actually contracted through the camera. And then we get a read back to our EMR within about 24 hours, sometimes 48, but pretty quickly. So this is our data from our main location. Again, just showing that you can kind of see at the bottom here when we started intervention and when we got that camera in the spring of 2024, you can see that in both patients with type 1 and type 2 diabetes, the percent of patients that got the retinal exam just pretty much exponentially went up for us. And then this is our second clinic location. So this was our second primary location, and we got a RetinaView there in early 2025. So we were able to prove in our first location that it worked so well that we were able to secure funding for another camera. So we do have a camera in our second primary location at this point in time. We don't have them for our other outreach clinics as of now. So just conclusions. So the standardized documentation really improved our ability to identify eligible patients for retinal exams. We involved the entire team, not only providers, but the nurses and medical assistants as well. The in-clinic RetinaView camera was pretty pivotal for us as far as improving our screening rates. We have had no billing complaints thus far, and it's been almost 2 years that we've been using it. It's been really fast turnaround. And for anybody that has abnormalities, we then refer them on to see an ophthalmologist in person. And then, as I mentioned, we were able to secure a second camera for other location. Our new challenge is we have a new EMR as of September. And so we didn't manage to do any eye exams in September because we could not figure out how to get it integrated and how to bill for it. So we are back happily online doing them as of October. But we are still figuring out what the documentation looks like and how to track it over time. And we moved to Epic, yes. So any questions or other comments? Yeah. Oh, so.
You mentioned that the picture gets sent to people you're contracted with through the camera. Do I understand correctly that that's through RetinaView, not through your institution?
Correct. So we looked at different options as far as who would be reading the pictures, and we looked at our ophthalmologist or contracting with people through the camera company, and it was more seamless to go that route. And so we've just contracted with them, and they are the ones that read it.
I'm glad you commented about the billing complaint, because I think a lot of people wonder about that. And this is a weird question, and maybe you might not have an answer, but as someone that sees an eye doctor, I have really funky eyes that have nothing to do with my diabetes, but that also has to, get the screening. Does that come up at all in your patients that you're like, oh, you need vision screening, not just retinopathy?
Yeah. So in our patients that wear glasses, we typically will say, you still need to go see your eye doctor. And so a lot of them opt not to have the vision screening done in our clinic because it would potentially be an additional cost for them.
But that's why you have those questionnaires, so you can still document that they're getting it.
Okay. Yes. So for those that go elsewhere, we can still document that they went in September and all was good. Yeah.
Elizabeth from Johns Hopkins. Just curiously, what percentage of your patients had referable diabetic retinopathy, and were you tracking whether or not they made it to an eye doctor if they were told to go?
Yeah, that's a really good question. A very small percentage. I have had maybe 2 patients that have had any abnormalities, and one was a coloboma. So I don't have great experience with that, and as of now we are not tracking if they make it, but that's a good point. I think individual providers, it's presumed that the individual provider would sort of make sure that that happens. But as far as documenting that, no, and that's probably something we should look at long term. I will say the only downside of the Retina View camera is if there is not a big difference from the eye color to like the pupil, it has trouble with that picture. So occasionally we cannot get the picture done in clinic, and it's for people that have like much darker eye colors. Any other question?
Another kind of billing question. I think when we were thinking about doing it for UCSF, the cost for like it was like a rental cost for the ophthalmologist to read. Is it expensive with it?
So the upfront cost of the camera is not insignificant. It's expensive. And then there's an ongoing cost, like a monthly cost for like upkeep of the camera and for the reads and that contract cost. But if we did, I think it was like if we were able to do about 20 a month, it would pay for itself, that sort of ongoing cost. And we haven't had trouble hitting that at this point. So it's really the upfront cost that ends up being the big kind of lift for a clinic.
Thank you.
Yeah.
Allison, thanks so much. Is it a charge that the patients see, or okay, so
Yeah,
it's sort of an additional increment?
Yeah, it's not lumped into like our clinic fee. It is a separate charge. And so we let patients know that. Okay. All right. Thanks, guys.
Thank you.